So I wanted to make a video for those of you who are working in critical care at the moment during the COVID crisis and are reasonably unfamiliar with the working environment. I'm very well aware, as are all my colleagues, that working in such an environment when you're not used to it must be quite a scary prospect. And one of the things that strikes me is that as you walk in, there's a patient in the middle of it all, of course, but they're surrounded by lots of machinery which you may not be very familiar with. So I just want to try and explain some of that machinery that is around the patient and hopefully give you an understanding of what it means, what it does, and just to help you work your way through the day with a little less trepidation than before. So in this video I'm going to talk about the monitor, the ventilator and the infusion pumps, which are the main pieces of equipment that you're going to see around the patient. Now, I'm not expecting you to be experts in these once this is over. This is very much the basics, an introduction, just to make it a little less scary and give you a more understanding of what's actually going on. So let's crack on. So you'll have to forgive me, I've not used this piece of software before, so let's see what we can do. So let's start with the monitor. And my pen's not writing, so that's not a good start. Why is my pen not writing? Let's start with the monitor. There we go. Okay. So this will be the monitor that is usually behind the patient. Now we're all, if we're nurses, used to the basic observations, aren't we? So let's break this monitor down into its various lines. So if we start with this value up here, 80, and what's going on up here. So this is the ECG. Okay, ECG. We're all reasonably familiar with those. So this is the patient's heart rate. This is the ECG. Now, commonly, a lot of our patients in intensive care will be tachycardic. They'll be above 100 beats per minute. Some of them can be 110, 120, and you'll notice that we probably, on the whole, are not too worried about heart rates like that. A lot of them will be in atrial fibrillation. We're not expecting you to recognise that. And a lot of the time, because they're in AF, again, we're not too concerned. We may or may not be treating it, depending on lots of factors. But that's often why they can be a bit tachycardic as well. Or they could just be a sinus tachycardia, so they're just a little bit tachycardic, and we may or may not be treating it. So if that's a little bit faster than you're used to, it's not that unusual in intensive care. So the next value down, we'll do it in a different colour because we can. So the next value down here is the SATs, which we will often abbreviate to SaO2. And this is the trace, obviously, here for the patient's saturations. Now again, during the COVID crisis, we are witnessing patients with much lower SATs than you've got here, for example 97%. We are tolerating 88 to 92% on the whole for the patient with the COVID lung, if you like. So you will probably see SATs lower than 97%, and indeed we probably don't want to see saturations quite that high, because that potentially will have an effect on their carbon dioxide levels as well. So you may see us being happy with SATs of 89, 90, 91, 92 because of the nature of the disease. So that's the saturation. You can see here we've got a very nice saturation waveform. Sometimes that can be a bit variable. Sometimes it's not picking up too well. But, you know, it's things like, is the patient cold? Is the probe on the finger properly? Is the patient shivering or shaking? Has it fallen off? So check all of those things when your saturations start to fall. The next value you will see is this one here. And this is the invasive BP. Now, most of the patients in ITU will have an arterial line. So usually that's placed in the radial artery in the wrist, left or right. Sometimes it can be in the femoral artery, sometimes it can be in the brachial artery, a bit higher up in the arm. But as a consequence of that, we're very fortunate to get a consistent blood pressure. You'll see it changing all the time, almost beat to beat, that we'll get a different blood pressure. You get the waveform next to it. So this is the waveform here. And again, that can, what we sometimes call, be damped. So the waveform doesn't look quite as clear and as good as it should do. That's the vagaries of an arterial line. So sometimes the blood pressure can look really, really low, when in fact it's just with a little cock of the patient's wrist you can improve the blood pressure. Blood pressures, again, can be quite low. In intensive care, we'll often tolerate blood pressures of 85, 90 systolic, whereas if you're working out on the ward, you're more used to 100 plus, certainly. And we'll probably be giving at least some of these patients some drugs to improve their blood pressure, and I'm going to talk about that when we get to infusion pumps, so I won't talk too much about that now. But the arterial line, we can also take blood from, and we do that quite frequently for arterial blood gases, which I'm not going to cover here. And we can take blood samples as well from there. So very, very useful, which is why almost all of our patients have an arterial line when they're put into intensive care. The next line I'm going to talk about, and I'm not going to talk about the one that says PAP below it, because that's not something that we commonly use in most intensive cares. That's pulmonary artery pressures, which I'm not going to talk about. But the one that's interesting to us next is this one here. And this is the ENDTidal CO2. So what does that mean? Basically, we have a little monitor, a little bit more tubing at the end of the patient's endotracheal tube, which is sampling the gases that go past that tube as it goes past. And it's telling us what the carbon dioxide levels are that the patient's breathing out. Now, this can give us a good indication of how well ventilated the patient is. And you get this, you consequently get this waveform here. Okay, so slightly non-intuitively, the carbon dioxide levels will go up when the patient breathes out because they're breathing carbon dioxide. It will then plateau as the patient's breath continues, and then it will go down as the patient breathes out. So that's why you get this waveform here. Now, the ENDTidal can be measured in kilopascals or millimeters of mercury, so you might see slightly different numbers. This is kilopascals. Millimeters of mercury is a slightly different value. But just find out what you use in the intensive care you work in and establish what the normal values are. And somebody whose ENDTidal is rising or really high is not ventilating particularly well. If they're really, really low, and then we perhaps need to reduce their respiratory rate, for example. Okay, so that's the monitor. They're the common things you see on the monitor. They're alarming a lot, and one of the pieces of advice I give to any ITU nurse is to decide what you're willing to tolerate with your alarms. So if they're banging away at 110 and they have been for hours and we're not doing a great deal about it, it doesn't make any sense to have your alarm rate set at 105. Because it's just going to alarm constantly. You're going to be pausing it constantly. You're not doing anything about it, so you don't need to be told about it. So, for example, you would set your alarm rates maybe at 115 to 120. So be aware of your alarm limits as well. And obviously, if you don't work in critical care and you're one of those lovely people who've come to help us out, then be advised from your ITU nurses. Okay. So let's talk next about probably one of the scarier pieces of equipment if you're not familiar with intensive care, and that's the ventilator. Again, the ventilator commonly sits behind the patient or maybe just to one side. And I'm not going to go into too much detail here. This is a Hamilton screen. The screens will vary, but they've got certain key essential pieces of information on there that you will commonly need to know, and you will probably be asked to record. So it might be useful here just to cover some of those pieces of information, just to give you some ideas as to exactly what it is you are looking at. So the ventilator will be breathing for the patient, and it will be breathing for them at a certain rate, at its basic level. As the patient starts to wake up, the patient will start to take some breaths, so there would be more breaths taken, but I'm not going to talk about that. I just want to talk about the basic settings on the ventilator. So here we can see this number here, F total, and F stands for frequency. So how much is the patient breathing? And here they're taking 14 breaths a minute. So by the patient breathing, I mean, is the ventilator breathing for them, or is the patient breathing? It could be a combination of the two. The patients that are very heavily sedated, it's just going to be the ventilator delivering the breaths. So that's the frequency. That's one thing that you'll be asked to record. Up here, again, something you're going to be asked to record is the peak airway pressures. So peak pressures. Now, we in intensive care, for various reasons again, and I'm not going to go into those details, but for various reasons, don't like this to go above 30. It damages the lungs, and we try and keep it below. Now, what I'm finding from experience with the COVID patients, that these airway pressures are commonly well above 30, sometimes 32, 33, 35. We try not to let that happen. Sometimes we just have to live with it. But if we can, we'll get those pressures down. So that's something else you might be asked to record. Next here, we've got what's called the tidal volume. So TV equals tidal volume. Now this basically is in mils, how many mils is in each breath the patient is taking. So you and I would take somewhere between 300 and 450 mils with each breath, depending how big you are and how deep a breath you take, obviously. But the average breath, 350 to 450 maybe. So that's the tidal volume. So how big are the breaths the patient is taking? And again, one of the things that we try to achieve in intensive care at the moment is 6 mils per kilo for the patient of ideal body weight. What do I mean by ideal body weight? Okay. Let's say you are my height, 5'5". I'm short. For those of you that know me, I'm short. But let's say I'm 5'5" and average weight. Okay. My lungs are a certain size. Now, if I'm 5'5" and really obese, the size of my lungs doesn't change. My lungs don't get any bigger. My lungs will be the same. So we need to work out what the ideal body weight is. And we do that by measuring the patient and then comparing it to various charts. And that tells us what the patient's ideal body weight is. So if my ideal body weight was 70 kilos and we're aiming for 6 mils per kilo, you just multiply 70 by 6 to get my ideal tidal volumes. But tidal volumes is something you're going to be recording on the charts as well. The other thing that you will be recording is something called the minute volume. And that really is quite simple. That's the tidal volume multiplied by the frequency every minute that the patient's breathing. So if your tidal volume, let's make the maths easy, was 500 mils and you were breathing 10 breaths a minute, your minute volume would be 5 litres or 5,000 mils. And that's something else that you might be recording. You might also be asked to record, and let's do this in a different colour. You'll be asked to record this value here, which is called the FiO2, or the percentage of oxygen they're on. FiO2 is fractional of inspired oxygen, so the concentration of oxygen you're giving them. And here, for example, it's reading 35%. Sometimes you'll see that written as 0.35 because it's a fraction. So 100% would be 1, Anything less than that would be point something, so 0.7 would be 70%. But most commonly on charts, you'll write it just as 35% or 70%. A lot of our patients will be on a lot more than that. A lot of the COVID patients are on 60 to 70%, for example. So that's something else you might be recording. And then the last one I'm going to say on this one is the PEEP. So PEEP, positive end expiratory pressure. When the patient breathes out, the ventilator will leave a certain amount of pressure in the alveoli so the alveoli don't collapse completely. They would never collapse completely anyway because of things like surfactant, but we want them to collapse even less. And it helps recruit those alveoli that are prone to being collapsed. So PEEP of 5 is quite low. You can find PEEPs of 10, even up to 15 to help recruit those lungs, to help improve the oxygenation. So that's what PEEP is for. And again, that's something that you might be recording on your charts. Okay, so that's the monitor and the ventilator. The last thing I wanted to talk about, because this is something you're going to be dealing with quite a lot, are the infusion pumps. So you may see a bank of pumps like this next to your patient. There may be 1 or 2, there may be 4 or 5. And these basically are giving the patients the drugs they need continuously. And there's a number of drugs that you're going to see very commonly. And let's just talk quickly about those. So there's going to be drugs to keep them asleep, the sedatives. And the most common one is propofol. And if you work in theatres, you'll see propofol all the time. It's what anaesthetists commonly give to send their patients off to sleep before they put them on the anaesthetic machine, and then they use the anaesthetic gases to keep them asleep. But we use propofol at rates of 1% or 2%. We commonly use 2%, so slightly stronger strength. We use propofol to keep the patient sedated. Now, one of the downsides of propofol is it tends to vasodilate the patient, so it can drop their blood pressure a little bit. And if they're shocked, that can cause issues. The other drug that we'll commonly use is a strong painkiller. So we'll use something like alfentanil as a painkiller. So you'll see propofol and alfentanil. Now, one of the things that's happening occasionally for us is because we're using such high amounts of these that our stocks are running a bit low. So in that case, we'll go over to something like midazolam and morphine. Now, the drawbacks to these, midazolam is a benzodiazepine. The drawbacks to these is that they are much longer acting than propofol and alfentanil. Propofol you'll turn off and the patient will start to stir within half an hour possibly, maybe a bit shorter, maybe a bit longer depending on the patient. With things like midazolam and morphine, if that runs for any length of time, the patient will take quite a long time to wake up once you've switched them off. But needs must, we need to keep the patient comfortable, we need to keep them sedated, so those are the drugs that we may or may not use. So the other drug we need to talk about is something to paralyse the patient with. We need to paralyse the patient if the ventilation is becoming difficult, and we need the ventilator to be working more efficiently. So using a paralysing agent is one of those options. Now, there are various agents we can use. The one we use in our trust at the moment is called atracurium. And that'll run at rates of, say, 5, 6, 7 mils an hour to keep the patient paralysed. We don't like to use this for too long because it can have implications once the patient wakes up. They can become very weak as a consequence of having been paralysed. But that's another drug you might see. Another very common drug you will see being used. Remember I said that propofol can drop the patient's blood pressures, or if the patient is shocked, you might need something to improve the patient's blood pressure. And what we commonly use for that is noradrenaline. Now, noradrenaline basically is what's known as a vasopressor. So this will cause the veins to constrict, and as a consequence, that will raise the blood pressure. So these are the most commonly used drugs that you will see. They'll be going via these infusion pumps to the patient. You'll see the lines, and it's important that they do run continuously. You will be asked to record the values of how fast they're running, and when changes are made you need to record that as well, so we know exactly what the patient is on. So that's my quick whip round of some of the machinery around the end of the patient's bed. I hope you find that useful. I'm probably going to talk about things like arterial lines and endotracheal tubes in a bit more detail in another video.